Okay, so this is my intention of that was to set a day because you guys were just pushed in the water and said, "Oh, let's just start swimming." So I wanted to give a big overview. A lot of the stuff that I put in here, you already talked like randomly here and there, but um, I put it together as you can see. I put it in there, so it's mainly expert opinion thing. I didn't go after literature. And of course, I try to do everything I do based on evidence, but I didn't put this literature together based on lectures and data and all of that. It's just clinical practical tips, literally. Just few practical tips. And the thought process was I thought about focusing on something, just day one or something. Then I figured it's not going to give much value to you guys. We have limited like a couple hours. So I thought if we do like a 10,000 feet view, that would be better. So you get a picture of the whole city instead of having a view of a neighborhood. So that's what I put together. Almost most of the slides can be one separate lecture on their own. Like I don't know how many slides is there, but every single one of them can be one separate lecture. So if you felt like we have to pause or expand on one of them, let's pause me and we do that, talk about it. The idea is just to talk about initial exam, those are the case selection criteria, the records, treatment planning, common mistakes that I made them all and everybody makes them, aligner delivery appointments, progress, comfort visits, debonding, and retention. So basically it's the whole picture, which is a big textbook, or it can be a whole semester of 2-3 semesters of, or maybe the whole orthodontic residency. About the initial exam, did we talk about this red, green, yellow thing?
We just mentioned. Yeah, you mentioned it.
I briefly mentioned it. The idea behind that came when I noticed in like a corporate setting, I spend only like 2 minutes with the patient because there's like 10 new patient exams, 80 patients are scheduled to be seen, there are 4 assistants, and it's never like one in academia will do like go get the records, sit down, do the treatment plan and all of that. That's the ideal. But real world was not like that. So I figured I find out myself that I'm doing it like literally in 2 minutes. I know if this patient is good, I tell them, okay, let's get the cavity clearance form and start. Or this patient is, no, I gotta do homework. Or this patient is like, let's send them to someone down the road or send them to academia. Then I came up with that idea, and we were actually working with residents here. I figured if I can transfer that kind of knowledge and make it a system that you can also get in, and in 2 minutes you know, okay, if this is a patient I'm going to start working on, or no, I rather let me call Payam and see what he thinks, or not at all, I'm not going to touch it, let's send it out. And I came up with that. It's pretty easy. You can get a printout of this, and it basically went, and there's a whole hour and a half lecture I put for just this table together. If we have time, I would love to share that with you guys. It's diagnostics, but practical diagnostics, not the diagnostics we get in the dental school with digitizing and analysis and all of that. It's really very practical to the point. And if you see like 2-3 patients with this, it becomes like a second nature. You don't even have to do a lot of work on that. And you can see just 3-dimensional, transverse, vertical, anterior, posterior, and then skeletal, dental, and soft tissues. You look at all of that, and as soon as patients walk in a matter of like 2 minutes, literally in 2 minutes, you know where's the patient. Is it green? Perfect, let's start. Feel confident. It's a yellow. Let's take record. You're not going to do anything yet. And it's red. It's out of the scope of the practice. So that would be the initial exam. And as I said, think about all of this as like a big picture. Aligner therapy. Go ahead.
Can you briefly touch on the difference between like a maxillary mandibular transverse discrepancy versus a crossbite? Would they be one and the same, or how would they differ?
I was looking at, I put this as a skeletal. Oh. Is there a skeletal discrepancy? Okay. Is there a dental discrepancy? That's what I put this right here. That's why it gives you like easy numbers down there, and then you have somewhere between 0 to 32. And of course, this is just personal experience. It's not data, it's not literature. And in years I've seen about I would say even more than 50% of the patients are in that green category. So with confidence, you can start it. It is in the scope of general dentistry practice, and you can do that. About 20%, I would say, are in that yellow zone. You got to take an X-ray, do further homework, and about 30% may be red. We can change that. Hopefully, if it takes off, then somebody's going to do research on it, and we have some accurate data. So that would be a fun study to do. But you can see that's what like facial type is just facial. So there's like two things that you can patients walk in facial, and then the rest is the skeletal and dental. Asymmetries, of course, on all three levels. You can look at the asymmetries. And of course, it's a table work in progress. So when you do it, if you see certain things that you pay attention in clinic, you can modify that based on your own needs. It's not like a set in stone thing. But it's really important to have that idea of green, yellow, and red, because usually in lectures, or at least the nano experience that I experienced, it was like, woo, just stay away from this, send them out. But that's not true. And then that's the trouble that happened. We talked about it. A lot of colleagues get into start cases that it's not in their scope, just being a rebellion against what was taught in the school, and everybody gets in trouble, patient, doctor, and everything. When in fact, an honest conversation can save everybody from that headache. Case selection, that's actually that's very important, how to select your aligner cases. There are certain things, of course, again, this on its own, it can be like easy an hour lecture with a lot of examples and pictures and all of that to review. But these are the main key points. If in vertical dimension, you look at if patients have like severe deep bite, then they're usually not good candidates for aligners. And the reason being, aligner by nature, because it covers the teeth, it deepens the bite. So when you have deep bite, and there's appliances deepening the bite, so you have to fight against it. Even I tell patients with deep bite when they insist they need aligners, I always tell them that you got to expect a little bit longer treatment time, or we might not even be able to fix your deep bite. Depend on if they are brachiocephalic or dolichocephalic, or what is the masseter muscle forces, if the patient is strong or like hypertrophic or hypo, whatever it is, the strength of their muscle. So that's one thing. Open bite cases, in like average open bite case, let's say I have 1 or 2 millimeter just anterior open bite, is okay. Aligners are perfect because they have that bite deepening and it works. But if it's a severe open bite case, close to surgical range, then it falls on that to the red zone. And in transfers, the crossbite cases, and you can see, like a case like that, it might look easy. Oh, perfect, simple crowding. And I've seen colleagues, they treatment plan this for a Invisalign Lite 14 aligners and say, okay, I'll take care of that. And then they end up having posterior open bite, which we're going to talk about it, and it becomes a big trouble. But it's deep bite, you always have to put it in the yellow zone, I would say. If it's
what would you classify as like very deep versus just a slight?
Very deep. Remind me, take a little note, remind me, I show you a patient. It's like okay. 110% deep bite, and patient is in mid-30s. Jacqueline, if you take a note, put somewhere that I can show you Jacqueline on my
so like a moderate deep bite would be okay, or mild?
Moderate deep bite is perfect. Even this amount of deep bite, you can do it, but you have to expect a little bit longer treatment time. Okay. Possible challenges that come with it. It's better to not to do it with aligners, because with braces, if you do it with braces, by nature braces will open the bite. Right. That's perfect. So that's ideal. For open bite cases, if they're moderate, as I said, about 1 to 2 millimeter open bite, and it's just canine to canine, it's because of thumb sucking or something like that, right, then it would be ideal. But it's like 3 or 4 millimeter open bite and only first molars are touching, then definitely not a good idea. And the reason being for open bite cases, because one of the unreliable movements with aligners is extrusion. You can't do this with plastic. We talked about it in the clinic too. So that's why then you need attachments, and then if it doesn't track, so you'll never be able to make that extrusion, the treatment will never go anywhere. And the class 1, 2, 3 correction, in teenagers and younger individuals, of course, if they are compliant with their appliance and the rubber bands, because it's a lot on the patient. It's completely out of our hand when it comes to rubber band wear. it's possible to think we can fix up to 3 millimeter with good rubber band. And it's by textbook. 3 millimeters is that limit. Beyond 3 millimeter bite discrepancy, we can't fix it with rubber band. Then you have to think of extra auxiliaries, courier motion appliances, or different appliances that are available. And when it comes to aligners, it's a little bit more even challenging because patients who want the aligner, they're already doing a lot of hard work to wear the aligners and be compliant with that, and they don't want to show anything and putting a rubber band on. If you put a button and then haven't wear rubber bands, it's going to show something. So it's very possible that they don't do that. Even though they want to, they try. So you don't get much correction out of that. There's a movement in orthodontic world for the past, I would say it's 6-7 years. Courier motion appliances. Dr. Courier, I think he's French or from Italy or something. He invented this little device. I can show you a picture later. If you put the Jacqueline's name, I'll show you that picture later on. You basically start AP correction first, and then you start braces or aligners with a limited appliance, and patients do that. So that's also an option there. I haven't used it. I haven't bought into the idea. I've been to multiple lectures and listening to what they do. A lot of orthodontists implemented that, but I haven't. Courier motion is there. Is an option there to do the AP first and then move forward. And that actually became very popular because of aligners. So they give the courier motion first, correct the class 1, class 2, class 3 initially, and then scan the teeth to start the aligners. And that would be a good conversation to have. So with that, we're looking at those three. When you want to select your cases, look at all those 3 dimensions. See, 3-dimension 3 tissue is I forgot the name of the orthodontist in Dallas. He basically Baylor Dental School. He created that little diagnostic system, 3D, 3T, 3 dimensions, 3 tissues. Every patient's come in. Maybe for dentistry, we look at the tooth and the periodontium, but for orthodontics, you got to look at all these 3 dimensions. And you have this structure in your mind. I'm looking vertically, transverse, AP, soft tissue, skeletal, dental. You cover the whole thing, so you're not missing anything. That would be a little checklist. And in about that diagnostic part, again, I have another hour and a half lecture. Just this, I think I shared with Betsy's class about that diagnostic. That would be a fun lecture to have. That gives you also, it's very practical. So with that saying, then the lower on the green score, the better for aligners. It's easier to manage. You know with confidence that you can finish it up and you're not going to get stuck. And basically mild to moderate overjet, overbite discrepancy. You're familiar with overjet and overbite for sure, right? And then simple cross bites. So a cross bite like this, I would recommend it. Especially young kid, we can see primary teeth. It's a young kid, we don't know where the growth is going. Doesn't matter as much as Invisalign push to do Invisalign teen and give you a discount or whatever. You don't want to get into that. But a cross bite like that, just 1 tooth, young kid, if it's compliant, then we can fix that. Then aligner would be a great appliance for this kind of cross bite. About posterior crossbite is a little bit based on the case. It's hard to come up with certain rules because some posterior crossbite, even with literature, Dr. Kokich has a couple good publications on that. It's even better to keep that posterior crossbite there, not to even touch it. It would be healthier for the patient. And depending on the cortical bone thickness and the health of the mouth and the gingival tissue and all of that, then it's a judgment call at that time for posterior crossbite to use it. But the good thing is with aligners for expansion, it works really well. So if you want to expand the case, because aligner every time, at every stage, they add a little bit of 0.2 millimeter expansion, the aligner stays engaged with the teeth. So all the other movements also happen really good. So if you know in case it's getting expansion, you know the aligner is going to work better compared to other movements. And then, of course, class 1 is easier because you don't have to deal with rubber band or anything. And then mild to moderate crowding. Definitely don't go to the route of severe crowding. I try not to do severe crowding with aligners. I've done few over the years, but it takes a long time to unravel and correct the rotations and all of that. Patients get burned out. Usually patients, up to a year, even the most compliant one, they do great. But when it goes beyond a year of treatment, they get burned out. It's better to have them in braces or something more fixed. And then, as I said, 6 to 12 month expectation. So we did the case selection. It's a nice class 1 or mild class 2, mild open bite, mild deep bite, and all of that. You selected the case. Now it's the initial record. With the documentation is always the most important part with ortho because it's possible that it gets lost in the excitement of seeing patient excitement, having a lot of conversation. Because let's say when I was doing a root canal, patient will come in with the pain, and I'm looking at tooth, do the cold test, heat test. I'll do the root canal, give him medication, patient is out. But with ortho, I'm looking at 3 dimensions, 3 tissues, and patient character, internal motivation, external motivation, and all of that. So it's possible that the documentation get lost. And by the time that case gets in trouble, it's like 1.5 to 2 years in the treatment, and it's really hard to go back and to fix that problem. And of course, cavity clearance would be number 1, and perio release would be number 2. Perio problems is number 1 lawsuits in orthodontic cases. So you want to have a perio release. For you guys, because you are the general dentist and you have all the perio records, and I usually send it to my general dentist to give me cavity clearance. So that's great for you guys because you have it, you sign it off for yourself. You say, I checked it, everything is good, ready to go. No gum problems, no periodontal issues, no cavities, and so that would be important. And the consent form. American AAO has a standard consent form. That is great. It can be used, and I have a copy I can give you. It's available online too. And there is an Invisalign has its own consent form. It's nicely put together too, and you can use that. I would recommend use that versus your own office consent form because they worked on it. Maybe you want to get in there and tweak if you want here and there, but I don't. I literally use what Invisalign provides for any aligner cases that I do, and the American Association of Orthodontics for sure for most of the cases. That's very important. There are, of course, there are nuances on how to present it, who presented, and where to sign. But keep that in mind. The photos is definitely composite 8 photos. These are the standard photos you want to see. On deep bite cases, it's always good to get a half open shot so you can see the incisal edges. And even I'm guilty a lot that I missed that shot. I'm starting to just remind myself to do that because then we get to the finishing point. I don't know where at the initial part of the treatment, I don't know how the incisors are looking. So that's a good shot to take. The 5-second video, it's not, you don't see it in a textbook or anything. I literally created that for our program, and it turned out to be great because with our dentists that I work with, now everybody knows the 5-second. If they have a question, they shoot me a 5-second video, and I see functionally and crowding and everything in 5 seconds is there. And you literally can have patients to smile like that, open, close, and 5 seconds, you have everything in there. That gives you an idea. So the 5-second video is even for yourself is good. Patient come in, take a 5-second video. And then, of course, you need pano, ceph. It's good to have it, especially look at this case, the jaw discrepancy and all that. That's the only way you can see it. It's on the lateral ceph. And the pano, and if you have CBCT, then you don't need the pano, so you just get the CBCT. ITero scan we know, and additional records is basically based on your clinical judgment. Is there a pathology or whatever is going on?
Another question for you.
How
much are we expected to do with this, like SMA, SMB, all those tracings again? What are we expected to do with the set prior to starting with Invisalign or any other kind of clear aligner?
If your case fall in that green range, 99% you don't need it because everything is within normal range. But if not, you don't even need the numbers. Of course, you got to study a few of them to get an idea of what is the average range for SNA, SNB, lower 1 to SN. These are like important numbers to have an idea or have a little cheat note on the side. But I know a lot of orthodontists that start treatment without any lateral set. They're doing good. Unless they're suspicious about the lower incisor position, then take a lateral set to see if the alveolar bone, how thick is the alveolar where the teeth are sitting. Or if the patient like that, you don't need the lateral ceph to know this is a skeletal discrepancy, it's a class 2. You know? So you don't necessarily need that. But as I said, if it falls in that yellow category, then yes, it's a good idea to take it to see, okay, where the lower jaw is, where the upper jaw is, what is the angle of the lower upper incisor to SN, lower incisor to mandibular plane angle, and what are the discrepancies between the upper and lower jaw. Those are the like 5, 6. In the past, we had like this so many different analyses, as probably some of them they presented to. you guys at the school, but ABO came and summarized it to about 10, 12 numbers. And those are best. ABO, and if you go on any software or if you want to order your imaging to imaging center to do that, always ask for ABO analysis. That gives you those critical numbers and that helps you to make decisions. The other thing you can see out of the lab, which you can clinically easily see that, is the aesthetic line that goes from the tip of the nose to the chin. So in the lateral ceph, it measures for you this distance between the upper lip and lower lip to the aesthetic line. Are you familiar with the aesthetic line? Have you heard of that? It's literally the line that goes from the tip of the nose to the chin. And then you measure the distance of the lip to that. So if it's too far in, too far out, then you can decide about how much improvement you can make to that. And definitely on that, the diagnostic thing I have a really nice slide to share that with you guys. But did I answer your question?
Yeah.
You got it. Is it, the pace is okay? I'm not, I have the tendency to sometimes talk fast and mumble.
No.
I'm not doing that? Okay, that's perfect. There you go. So the next is, so we did the initial exam, case selection, records, and now we have the treatment plan. So we have the records, we have to do treatment plan. And treatment plan in aligner cases is clinical and also digital. So clinical is basically, it starts with setting objectives. And when you set up your objectives, first you don't have to worry about realistic. You see this kid, your common sense says, the lower jaw is back, the smile looks blah, 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 the teeth look blah, blah, blah. So let me set the objectives. I want to improve the aesthetic of the smile. I want to unravel the crowding. I want to correct their deep bite. So it's good if you write it down, better. If not, you keep a mental note of your objectives. What do you want to do? Where is the vision? What vision did you have for this kid or for this adult? You have to create that vision in your mind. And that's setting up the objective. And I always do not only envision the final outcome in a year or two, I look at patients' longevity of that smile. What about aging? What aging is going to affect their smile? So I designed a treatment plan for 30, 40 years down the road, and I set my objectives based on that. How much gummy smile do I have, and all that. And then what is the dental developmental stage? So you got to keep that in mind, the mixed dentition or permanent dentition. And then it comes from realistic. After you have that vision, of course, if patient is dolichofacial, long face, there's not much you can do. So it's not an objective that would shorten the face height. You never set that objective. And then after looking all of that, then selecting strategies and tools and techniques. That's really important. And of course, it takes basically the whole orthodontic world, orthodontic residency and education to make that kind of decision. But when you want to, this is basically all you have in any orthodontic treatment. So there's nothing out of this area that you can see here. You either have limited options with fixed or removable appliance. You have comprehensive, with or without surgery, comprehensive treatment with or without auxiliaries, and modality of the treatments are braces, aligners, or lingual appliances. That's it. So if you keep that in mind, there is no treatment, orthodontic treatment, that is out of this. This is basic, and you got to choose. Okay, I'm looking at this case. Okay, I'm looking at her. I need to do a comprehensive for sure. I can see it's in that yellow zone area. It's going to be comprehensive, so definitely not limited. Do I need surgery or not? I don't see any major discrepancies, the skeletal, AP, none of that needs surgical. So then it's going to be non-surgical. It's a comprehensive without surgery. Auxiliaries, do I need any auxiliaries? Maybe for, she's a little bit class 3-ish on this side, class 3 on that side. I might need some rubber bands. She's missing a tooth up here. I might need some extra auxiliaries to close that space. And it comes with aligners or braces, either one. And then, do I need to use TADs, mini screws to anchor and bring that tooth forward without pushing the front teeth back? So that comes with, okay, do I do auxiliary or not? Then you can decide after evaluating your lateral ceph, the position of the anterior incisors, the alveolar bone, and patient expectations, the time, and all of that you counted in there. Let's say this patient is comprehensive with auxiliaries, and okay, do I do it with braces, aligners, or lingual braces? And there's nothing out of those three options. This is it. There are some biomodality, hydro, some whatever. I've heard, I have a dentist friend of mine. She called, and one of the referrals, she called that her niece or nephew in Dubai is recommended to be treated with this appliance, bioactive something. It's like, and they have to wear, it's a body appliance, biofunctional something, and then they have to do it at nighttime. It's like a night guard with soft material. There's a bunch of those stuff out there, but this is it. If you heard any of those on my account, just ignore it. There's no science. And I've seen this, a friend of mine, this is a sad story. Relatively sad, no. He came to me and said, I saw this amazing dentist in North Phoenix, and he charged me about $2,000. I know this kid doesn't have a lot of money, does YouTube, and he hustles to make ends meet. And then he paid $2,000 to this guy, and the guy said, I'm a holistic dentist. It's like, oh wow, I never heard of that. I looked at his website. Of course, there's no academic credential. There's a bunch of, I'm holistic, whatever. And then I looked at everything. I said, can you share the information with me? The $2,000 what you paid for. There was a bunch of gibberish numbers and none of that. I never seen any books. I never read anywhere. And he already paid him $2,000 for just nothing. Nothing was done. It was all diagnostic and talk.
He's a dentist, though.
He's a dentist.
Okay.
He's a
He
dentist.
said no credentials like you.
No credential about the holistic part. Not the dentistry, but no, he has a DDS.
Okay.
Yes. It was the older guy and the dentist. But the fact that they charge, and I know he's my friend, I know he charged him the money that he doesn't have, but just selling him nothing, selling him air. So that's what I'm saying. If anything is out of these three, lingual, aligner, or braces, just ignore it on my account. But this is really good slide for you guys to keep in mind for your having an overall picture of orthodontic treatment plan. And then it's digital. Of course, now there's a lot of even braces company. 3M has its own digital platform, so you can set up your teeth, and then they send you a tray, indirect bonding tray to bond your braces on. There's a new system is out, Light Force. They basically literally 3D print every single bracket, clear brackets, to every single tooth. 3D print that. I invited the inventor. I think he's Dr. Griffin. He's a young guy. I think he would probably graduate around the same time as you guys. And he invented that. His dad was an orthodontist, and he did Harvard. And he attracted like $200 million in funding and innovation. We invited him to a study club here. Gave us a talk. It's called Light Force braces. You look at it. He did a great job. It's
What
really
is it made
good.
out of when it's 3D printed?
I don't know what kind of material they use, but they said they had the white plastic at the beginning, but now they have like clear, translucent.
These are clear brackets.
Clear
for
bracket.
Traditional braces. Or
Clear brackets, traditional braces, and they're custom printed to the tooth. So it's really, and you position the tooth, everything based on the software. The software will decide where the bracket goes. So the bracket positioning is not going to be a matter anymore with that. So you have a digital platform to set up your teeth, and then there's Brias, the lingual system that I use, and I think we are number one or just two people in Arizona that we're using it. Brias did the same thing. They did metal. I don't know if they printed or how they do it. It's custom metal-based lingual braces. And the lab fee, like Incognito had it 3M in the past for like $5,000-$6,000 lab fee, gold-plated, custom-made, whatever.
That's the lab fee.
That was $5,000-$6,000. Incognito still is there. But now Brias they did like for $1,400-$1,500. Custom-made lingual system. I would love to share some of those cases with you sometimes. It's just fun to see. So the reason I brought all of that up, in the past, it used to be only Invisalign and then ClearCorrect that they had the digital platform. So if I want to do a treatment setup, I would have to upload to Invisalign even if I didn't want to do Invisalign, to look at the teeth and review the options with patients and all of that. But we have now multiple digital platforms to use for this kind of stuff. And in digital treatment planning, of course, that would be something, even if you don't do diagnostic or treatment planning lecture and all of that, that would be great to dedicate just 1 hour like this, just to sit down and I'll show you my sequences of reviewing these clean checks. what I look at and how do I make a decision or where to move the teeth and what's going on. If we maybe we spend an hour and review 5-6 cases, that gives you guys a great grasp. Because in the digital planning, this is something really funny. I work in this office. The dentist, a young dentist, friend of mine, we've been treating patients together for a long time. And then Heartland Dental bought the company. And I've been encouraging him to do aligners. Let's do some cases together. I can help you. He was not doing it. Heartland started the course, invited them to Chicago or somewhere for a 3-day weekend course. He came in and he shared all his materials with me. Really nicely done Invisalign course. And he was like, Dr. Owtad, that's easy. I just submit the case and hit approve. That's best. Now I can do it. And he was like, what do I tell him? He's my friend, he's a professional colleague, and Invisalign just took him out for 3 days to tell him this plastic have brain more valuable than your brain. That was like sad to see. So I would really want you to keep that in mind. This plastic is literally a plier. You are the brain behind it, not the technician, not the aligner, not the IT. And I'm not saying it out of being old school or not trusting technology or like my dad never trusted the GPS. He would always follow his own path and GPS yells at him. Not because of that. There's no AI that can have the intuition, at least not yet, have the intuition to look at this patient and look at this gum and thickness of the tissue and everything and make decision, do I close this space or not? That is your decision to make. To look at the panel, see the density of the bone, look at the position of the teeth, the bite, the strength of the muscle, the facial structure, and all of that, and then decide what movements are realistic, which one is not. So the plastic don't have brain. Keep that in mind. If one thing is stick to you from this lecture, it is this one sentence. Plastics don't have brain, and don't let the aligner company deceive you any other way. As at the end of the day, they provide a lot of service and they help a lot to orthodontic profession, but they really impose this false narrative that we do the job for you, you just make money. Same thing that Smile Direct Club start doing it, but now it's going down. Because it's impossible. The variety between each patient, that's what makes it impossible. There's no two people that are the same. And that's the important part. And when you look at the digital setup, of course, it's the CleanCheck setup. They call it approver. Different platforms are different. You come up with a sequence of, and you can, and Invisalign provides the smile simulation now, right? Did you know that? So when you take the Invisalign photos with their own app, which you can download it on your cell phone, it uploads a photo for a smile simulation. This is the button for it. You click that, and it gives you the final simulation. Patients love it. I love it. I can see. And when I design the treatment, I look at the patient because you design the position, the teeth, and then you update this. You see how much changes, how much expansion, and what's going on. So it's a really good feature Invisalign added. None of the other aligner companies have. So that's about the CleanCheck setup. And as I said, we have to go over the details of that in another hour. But keep that in mind. First of all, you are the brain behind the product. Second, find a sequence for yourself between that 3D 3T thing. See which one do you like to look at the rotations first? Like I like to look at the rotation of the teeth first, and then look at the overall view, and then extrusion, intrusions. So I found a sequence for myself that works, and every time I follow that sequence, so I know I set up the teeth right. And you can find your own sequence. You might like it, you want to check the AP relationship first, and then move on to the next. And you go basically move your, same thing that we do with Suresmile, you move your arrow up and down, and every time you go up and down, you look at one thing. You look at this second molars, first molars, canines, bites, and everything, and then you make some decision in this fast back and forth movement. You can find out which one is realistic, which one is not, and which one do you want to do it, which one is in line with your objectives, which one is not at all. And that's important at the CleanCheck setup. Do you have any question in this world? Because we did some setups together in the treatment planning in the digital space. Anything comes to your mind? No? Okay. That would be something, hopefully we'll be able to set up an hour just to review 4 or 5 cases, not a lecture, just I'll go for 5 cases, how I treatment plan. Off of these platforms that is easier than Suresmile. Perfect. This is also very important. And again, each line can be one slide. Sorry, there's a lot of information in there, but each line is basically one slide. Common mistakes made, and I listed those. It's not off of the textbook, it's because I made them all myself more than once. And any of my general dentist colleagues that I talk to, they ask me about their aligner patients, they made these mistakes. Everybody, without exception. One is creating posterior open bite. And as you saw in your case today, so basically, if you don't compensate, if you finish ideal overjet, overbite, and bite everything in the digital setup, because the thickness of the aligner and the bite deepening effect that the appliance have, so you're going to end up with heavy anterior occlusion and posterior open bite. And in order to compensate for that, you basically add anterior bite ramp. I used to be selective on which patient I use anterior bite ramps, but now I almost do on every single case anterior bite ramps, because I found it two benefits. First of all, it prevents the back teeth from coming together. And the anterior bite ramps, it comes inside the plastic. You don't put anything on the teeth, so it's really easy. You just write an instruction, add anterior bite ramps, upper 2 to 2 or upper 3 to 3. And then the other thing, when the patients clench against that bite ramp, it helps a better fit in the front. So for the patient, for your patient today, that we are going to do mid-course correction, definitely add anterior bite ramp. Because by nature, every time she bites, she's going to clench, and patients have the tendency to play with that, and that's perfect thing that you want. It's like a chewy effect with that anterior bite ramp. Almost, I'm saying that 90% of my patients are getting anterior bite ramp now. The other thing is overcorrection for deep bite. As you see, we finished with 1 millimeter or 2 open bite. If the patient is like 110% deep bite, I'll go like 2 millimeter open bite. And I have multiple examples that I can show you in my patients that I finished them with like 1.5, 2 millimeter open bite, and they landed with like 20-30% deep bite.
So the deeper the overbite,
the more overcorrection.
Okay.
And in your instructions, definitely tell them to intrude lower anterior and extrude posterior. You compensate for that deep bite. If you want to intrude upper anterior, it's really important to keep in mind, you don't want to mess with the smile arc. You're familiar with the smile arc and smile line there? A smile line goes through the lip, a smile arc goes through the teeth. You want to make sure to maintain that constant in the smile arc. You don't want to open the bite and I made that mistake. I intruded the upper teeth. I was so happy, perfect. It's easy. I do half and half. The bite is open, but the treatment finished and the smile is like flat, which I didn't like it. Then I had to do refinement and correct it. Maintain that constant smile arc while you're intruding and leveling the curve speed. And then beyond that, then compensate with the lower arch correction.
You talk a lot about intruding, especially the anteriors. I see a lot of people kind of my issues here where the mandibulars are extruded a little bit and the maxillars are intruded a little bit. How easy is it to extrude and intrude anteriors?
Intrusion is easy. Intrusion is happen. But when you intrude the lower incisor, there's always a relative extrusion on lower premolars. And because on most of the cases you get this deep curve speed, so you always end up having 2 attachments on the lower premolars. So the aligner can do that relative extrusion on the premolars. But intrusion is going to happen. Easy. But the extrusion upper anterior teeth, especially lateral incisor, I think we have it here somewhere. Lateral incisor, the next item. It's hard because the tooth are small. 2 things is important about that. First of all, we got to tell patients these lateral incisors and the lower canines are tricky. Keep an eye about the tracking of those, and we have to keep an eye on them. Second, add like horizontal bevel attachments to the lateral incisor for sure. Almost, I would say 80-90% of my patients are getting lateral incisor attachments, even though I try to minimize the number of attachments as much as possible, and I'll tell you why. But I end up getting lateral incisor attachments and lower premolars attachments.
So when you put an attachment on the tooth, you're basically not moving it.
Sometimes you do. But let's say.
Okay, so you minimize movements. Those 2 separate things: minimize movement and add attachments.
Yes. Okay. Yes. Minimize movements of the lateral incisor and lower canines as much as possible, and then add attachments to those. And the other thing, Invisalign, even you submit the cases. We have it, so we don't have it here. Oh, too many attachments. When you submit the case comes back. There's like almost attachments on every tooth. The AI put attachments everywhere. And it's you that you have to look. The role of attachment is to give a better grip.
Yeah.
That's all. If the anatomy of the tooth is bulky, there's a height of contour that can hold the aligner in place, or you're expanding the tooth, there's enough engagement, then you don't need the attachment. But if it's a lateral incisor, flat, upright, then there's no way, then you definitely need attachment. So you've got to review almost on every cases, I delete about 30%, 40% of the attachments in there. And the other benefit that it has is when you have more attachments, you have more chances for attachment breakage, and you have more work to do clinically, and there's more things that can go wrong. If the attachment is slightly up and down, or patience is not compliant, certain movements is not good, the attachment itself become a source of not tracking, because the aligner doesn't sit there, sits on top of the attachments, it messes up the movements of the tooth, and suddenly the attachment becomes the source of problem. So you want to really minimize the number of attachments as much as you can. Some of the more senior Invisalign lecturers, I've been at their lectures, he had and he practiced in Scottsdale, he had like a brick-like attachment on every single tooth. And the first time I wasn't doing a lot of attachments at the time, I'm thinking, patients do aligners so not to have anything on their teeth. They want to. There's a reason. If you put every brick, like a big brick attachment on every single tooth, then what's the point? They have something on their teeth. It's not going to look good. And he liked it. I saw every single case that he shared with us. He had like big attachments in there. The other thing about attachments, Invisalign has this precision attachment, customized attachments that they like come two of them on one tooth for certain movements. Biomechanically, it's really good. I even created a little lecture. I studied the biomechanics of a textbook and all of that. But in practice, it's really not practical because those attachments are small and they don't fit. The aligner doesn't fit on top of that. It's hard to clean around them. So I would say one of the instructions that you get to Invisalign, if you can, preferences in any aligner platform that you do, always ask them to use single attachment. Don't use the double precise attachments, whatever. Just use single attachments, either horizontal bevel or vertical bevel.
These attachments, are these just like traditional bracket attachments for how do these work? Because I have no experience with these.
Oh, you haven't done any
attachments. I don't even know what they look like, to be honest.
Let's see. There you go. Let's look at this. Yeah. Look at this patient. This is the first one. I haven't done any setup of this.
Yeah.
This is my patient. Actually, I'm doing a Spark aligners on her, not Invisalign. The Ormco Damon, the new aligner system they created. Are you familiar? Spark.
Who?
Amazing. Spark. Ormco. Damon brackets. Have you heard Damon brackets? The self-locating. The same company. They launched new aligner company, which I really like. But so I submitted. Look at this. Every single tooth is getting attachment. She doesn't need that many. And these are the attachments. These are literally the template comes like a S6 retainer, and they have this empty space in here. You fill it up with composite.
Oh, okay.
And they're like low viscosity composites that you can use, but I would say use packable composites.
Okay.
They're a little bit harder to remove at the end, but they're more durable. They stay there harder. At the beginning of Invisalign many years ago, we used like fluable. I thought, oh, that's easy. It's fluable. It's thick, but they usually come off. You use like Transbond. They use the one that we use for bonding the bracket. Yeah. It just wears out after a little while. Packable composite, easy, accessible. You don't have to shop the market for those. And then you put this attachment. But for her, you have to do the dynamic. But her lateral incisor, see, this we are going to extrude this lateral incisor and this central incisor. This extrusion is not going to happen without attachments. Or this canine is like a nail, pinpoint, round, small. If I don't have attachment on this tooth, like the attachments that they put in here, it's not going to move. So I know I need attachments for those. But that's what the attachments are. There's a whole conversation about attachments that we can have.
Do they honestly, do they know how much bone, like, I know they want to get the teeth right, but do the techs take into account, like, oh, this is a really thin buccal plate here?
No, not at all. That's what happened to the patient that I showed you
I've seen, like,
months ago.
Crazy cases, but, so yeah, they're not really looking at bone.
No.
Okay.
Some of the, even with Brios, the lingual system, I found their technician to be one of the best out of all these digital companies so far. Because they're a young company, I'm sure they put in, not only the techs are really highly trained, I'm sure the doctors are overseeing the setup, and the software is nicely designed. Even with them, I submitted a case. That same patient that I showed you, the tooth was pushed out of the bone. I took a lateral ceph, the avulsion was very thin. I submitted to Brias because she now decided to do lingual. And they did the exact same thing. They pushed the root out of the bone. And what Invisalign does, Invisalign renders the gum tissue when you do that. But now the digital interfaces, they have the option. You can render the gum tissue to follow the movements, or you can keep the gum tissue where it is. If you have CBCT with bone, that would be perfect. Like Suresmile has one of the first companies who integrated CBCT with the movements of the teeth and all of that, which is fantastic. That's the ideal scenario. But if you don't have CBCT, which most of the offices that, at least the first few years that we get to work, they don't have CBCT. Then if you don't render the gum tissue around the movement of the teeth, it's easy to see how the tooth is pushed out of the boundary of the alveolar bone. Does that make sense? Mm-hmm. Am I explaining?
Yeah.
Okay. But with Invisalign, it's impossible. So you got to use your own. You look at the tip and torque and expansion to see where you are. What else? Too many attachments we discussed. About second molar extrusion, nothing too important. But when you treat the case, it becomes like a clinical headache. The final outcome doesn't make much difference because as long as the second molars are in good occlusion, they're going to land and settle in a good position eventually. But the problem is when they add extrusion to the second molars, it's hard to bond the attachment. Even if you bond, they break. And then extrusion is not going to happen with the plastic. And patients come in, the back of the aligner is bubbly out there. So they complain. And the solution to that is just intrude your second molars a little bit. Upper second molars, lower second molars, intrude them in your setup, overcorrect them. So by the time you're done with your treatment, first of all, throughout the treatment, you know the plastic is going to sit on that tooth because it's constantly pushing it up or pushing it down. So it's never going to get wobbly back there. And even if there's a little space between the aligner and the teeth, it's got to be on the first molar, which patient clench on it even better. So it's not going to make patient uncomfortable. And then at the end of the day, you might end up, you might not, because of that same effect that the appliance. You might end up with a little bit of open bite in the second molars, which is perfectly fine. Even in some of the old, like Dr. Alexander, famous doctor, he had like 3 textbooks on all of that. And his systems are really well respected in the orthodontic community. Still it is. He would push the second molars out of occlusion to keep the first molars into class 1 relationship and let the second molar settle over time. So that will be fine. So that's the second molar. And the space closure is basically, it's a judgment call. Invisalign says we do it. I've tried it. It's really hard to move the teeth bodily when you want to close the space. If it's a lower incisor space, perfect, easy, you can do that. But it's a premolar or molar space, I would say it's safer not to commit to that. And if you commit to closing those spaces, it's good to communicate with the patient.
So you're saying just by nature, you have some second molar extrusion? Is that match?
No, most of the setups, when you look at it, the software automatically extrudes the second molar. Because most of the second molars are kind of tipped out. The software will want to correct the torque. Basically, correcting that torque causes a little bit extrusion, relative extrusion.
Yeah.
But you program it to intrude, then it keeps everything in place.
And you don't need, so they try to correct that tip, and by virtue it's extruding, and you don't need an attachment for that, right?
That's the same thing. You got to look at the tooth, the anatomy of the tooth. If the second molar anatomy has like enough bulk and undercut and everything, no, you don't need attachments. And I try to avoid putting attachments on the molars because they break off. And usually molar has enough surfaces that the plastic will grip to the tooth.
So my question is this, because I know, especially during a lot of crown patch now, a lot of second molars are very short. So if I'm trying to design that purposefully for the restorative plan, can I just leave it as is rather than compensating with an intrusion?
Yeah, of course. Of course. That's what I said. The common mistake is second molar extrusion. If you maintain it there, it still is okay. Because the aligner is going to sit. It's not going to wobble. Because that's where the problem comes. Usually we don't have occlusion problem, all of that. It's patient's complaint. Patient comes and says, this is bothering me because it's keep moving around and it's not feeding. And halfway of the treatment, what are you going to explain for the patient? Oh, that's okay. Let it be. You know what I'm saying? But that's why this becomes the... a problem. And space closure, as I said, one thing is, I don't know if you knew or not, you can do lingual attachment. So if you want to move a tooth, let's say you want to close the first premolar space, and you want to move the second premolar and the molar move forward. So put a like horizontal bevel attachment on the facial surface and a horizontal bevel attachment on the lingual surface, and so the aligner can hold on both sides and then pull the tooth forward. And not to tip the tooth, just move it bodily. So that's it. And the other thing is realistic versus idealistic outcome. If it's like a, I don't know, 15, 16 millimeter space of the lower molar with the mandibular dense cortical bone, of course we can do it. It's impossible to do it. The software will do it for you. You put a click, boom, the software will bring it forward. But in reality, it's not going to happen. But it's an upper tooth, a spongy bone, and it's a 5-6 millimeter premolar space. Of course we can do that. If it's a lower incisor extraction for gingival compromised gum or things like that, there's really good, aligner does really good job. But you have to design the movements of the teeth and the position of your attachment to close that space without leaving a residue. But I've seen that mistake made a lot. Does that sound good? I think this is a very important slide because it's very common. If you avoid this, you're going to be already better than 90% of people who do aligner therapy, orthodontist or general dentist, hands down. Just this thing. I had one of my colleagues for posterior open bites. I've been doing that opening the bite and overcompensating for the past about 5 years. I learned from one of the senior orthodontists back then. And we were out in Brios with one of my colleagues. And he said, I know with aligners I can't level the curve speed, so I don't even try. And I have patients now that I overcorrected, and now they have a reverse curve speed. So I have to do refinement to bring them back to level. Of course, I didn't say anything because there was not the context that I can share with him, but sometime I will share with him. So that's what I'm saying. Even a seasoned, experienced, high-tech orthodontist, well-known, they don't know that they can do that, and they make that same mistake. That's what I'm saying with confidence. If you follow this and then pay attention to this, you're going to be better than 90% of aligner providers in wherever you are. Perfect. Keep going. I'm going a little fast now. The clinical strategy is important, and you end up building your own strategy. I've heard from Invisalign lecturers, aligner lecturers, my teachers, people that I work with. Everybody had different strategies, and based on all of that, I developed this for myself based on one main theory that I learned from Dr. Profit himself. You know, Profit, our textbook. Yeah. I met him before he passed away in 2000. I think it was 2008 or 2009 in Boston, AAO. And I asked him, we were just walking in the convention. I said, Dr. Profit, teach me one thing that I can stay with me for the rest of my career. He said, if your patient have good experience the first few days and the first few weeks, they're going to be extremely compliant throughout the treatment. And he quoted a few research of that. And that really stuck with me. So if you give patient easy experience up front, they're way more likely to like you more, to be compliant with your treatment options more, and to do better job, especially with something like aligner. That is essential. And I had a friend of mine, general dentist up in Scottsdale. She said, when I design my Invisalign cases, I put all the attachment that they want, and I do all the IPRs that they want, and I get them numb. I tell them it's going to be horrible. I give them heads up. I communicate with them. And of course, I share the same thing that I'm sharing with you. That miserable experience makes the patient, if they were supposed to burn out in 9 months, they're going to get burned out in 4 months after that hard experience. So that's why I adopted this strategy. The attachments come at stage 3. So aligner 1, 2, 3, which basically by design, when we go over that clean check, I'll let you know. I reduced the velocity of the movements. Instead of 0.2 millimeter and about 3-4 degrees, I saw that was in the booklet too. It was there in there too. Instead of doing 0.2 millimeter and 3-4 degree movements on every aligner, I asked them to reduce the velocity by 50% at the end and double the number of aligners. So now I know instead of 2 weeks intervals, I can use this aligner between 5 to 7 days. So the aligners are designed based on 5 to 7 days, but I'm going to tell a patient aligner 1 to 3, 10 days each. So I know for sure, first of all, it's going to be easy for the patient. It's not going to hurt. The teeth are going to track, so patient's going to look at it and feel it encouraged. And when they're ready to move from aligner number 1 to number 2, it fits easy, so that gives them that encouragement. And it's easy to maintain 10 days interval. They put it on the watch. Okay, 10 days from now they change it, and then they have 1 month. I do the standard 4 weeks or so, the orthodontic appointment. They make the appointment next month and they come in. It's easy to track, so all of that. So that would be like easiest start. Even with that, I give them an instruction. When you want to go from one aligner to the other, about an hour before you go to bed, take a Tylenol and put your aligner, the new aligner, on right at bedtime. And I always tell them, even if you do it during the day, it's okay, it's easy, there's not much pressure. But if you do it that at nighttime, then by morning when you wake up, you're used to your aligners, that you don't experience any discomfort. So it makes the transition really smooth. Patient will not feel the burden of aligner wear and only focuses, okay, how do I incorporate this thing in my lifestyle? When I go to restaurant, what do I do? How do I manage it in the home? How do I keep it clean? They focus on those stuff versus being focused on the pain of the teeth. So that gives them like higher. And I can say with confidence over the past, as long as I'm doing aligner cases, and since I especially adopted this strategy, 100% of cases that I design them with aligners, they finish the treatment with success. And spending a little bit more time upfront to set up the case instead of leaving the plastic brain to work for me, maybe 50% of them are going to need 1 round of refinement. Not even the second round, 1 round of refinement. And about 50% of them are done the first time, which is pretty rare. And these are just these few little strategies that I picked. And as I said, in your own practice, you might build your own strategy however you like, but keep that in mind. You have to have that set of strategies. And then appointment 2, they come back in a month. That's when you put the attachments on. And you tell them, okay, now the appliance is going to grip better. First of all, the attachments come at number 3. They've already been wearing number 3. So the teeth are moved a little bit. You put the attachment template, number 3 on, bond the attachments, and you have them to wear number 3 for another 2 days. First of all, it's not too long. A couple of days they can stay in that old aligner. And the only thing that's going to happen in the next 2 days, the teeth are going to get used to the position of the attachments and the movements and all of that. It's not going to be a lot of pressure on the teeth. So that makes the new attachment to attachment transition really easy. And they go to number 4, and we go from 10 days each to 7 days each. And I know that still I'm within that 5-10 days range, and every person is different. The other strategy is, so you tell them 7-day and on per aligner. And this is going to be for another 2 months. So we keep that 7-day. 1 week is easy for a patient to track. They put it on the watch or the Invisalign app, 3M app. Most of them, they're like online apps that they can track all of that. So you can download those and do that. And you go up to number 12 with that. It gives you about 2 months. So patient is going to have good experience with that. The important thing to communicate with them at this appointment is say, we designed the attachments, but because it doesn't matter how good of a job you do, sometimes these attachments break. Patients buy. Oh, the other thing, I forgot to add it in this slide. Sometimes when the software set up the attachments, especially on lower teeth, they put it too occlusal. It interferes from occlusion. They break. It's always good if you see some of those in like 3M and Spark. I can move the attachment myself. Invisalign doesn't allow to do that. So you got to give them the instructions. Say put the mandibular attachments as gingivally as possible to avoid any interproximal interferences. So that's a great idea to do that, to put that in there. And always tell patient, hey, I designed the attachment, I bonded to your tooth, everything is nice and stable, but I don't rely much on these attachments for your treatment. So if some of them break off, don't stress about it. Continue your aligners, and then we'll take care of that next time you come. Easy. If you don't do that, the attachment is going to break next day. Patient is going to call your office, and it's going to be next door. Say, oh my God, this broke my treatment. What happened to my $5,000 money? Whatever. That's going to become a problem. But if you communicate that with them, and most likely, most of the movements that you design is not going to be significant. And say worst case scenario, that broken attachment caused one tooth to stay behind with the treatment. Then you either pick it up at the next visit and bond, use the last aligner as your template and bond the attachment, or you wait until you finish your aligners and then fix that tooth in refinement stage. It's much better than patient panicking and stressing out about one little thing. So always have that communication. And then set patient expectation. Well, that's going to be a little bit uncomfortable, a little bit tighter than before because you didn't have attachment. And then the patient comes back in 2 months. And the good thing is with this, you can maintain this like 2 months, 3 months thing. And then usually around that time is you can do some of the IPRs depending on the case. It's ideal if you can do the IPRs, and you saw that you can have this dictate the staging in your aligners. I didn't know that until a few years ago. So you can dictate to the technician when I want to do the IPRs. Put the IPRs on a stage 22. Put the IPR at stage halfway through the treatment. So you dictate that. Because if you don't do that, then Invisalign, the software is going to randomly pick. As soon as the contacts come in contact, the teeth come in contact, they put the IPR. So you get your paper, it says this IPR is at the stage 3, this IPR is at the stage 7, and the other, it just become like a chaos. Then every time patient come in, you have to do the IPR, you have to keep an eye on the paper. But if you dictate to them, okay, I want to do IPRs at the stage 12, that you give patient heads up, next time you come in, we're going to do the IPRs, and then you do that. The other thing I didn't add in here, always, let's say 0.5 IPR, do 0.4 IPR. Just stay 0.1 less than what you recommended.
Why is that?
Because doesn't matter how accurate you do the IPR, you might not be 100% at the center of the contact. You might be slightly off one way or the other, and then you finish the treatment, the contacts are open. But if you stay 0.1 short, the contacts are going to be tight, and then you use that. Have you used that little gauge that you can measure the contacts? There's a little key gauge that are like 0.1, 0.2, 0.3, 0.4, 0.5. There's a little key. It's a thick, small. The thickness of that key gauge, you can go in the contact and check it. So you can do with a strip or disc, and then you can measure with that, so you know exactly where you are. So it's not like a guessing game. You can exactly measure with the gauge. So if it's a 0.5, do 0.4, and you're good to go. And of course, that would be like 4 or 5 slides just to talk about the IPR with aligners, and we can do that. But know that the nuances, in the IPR, you gotta use your doctor's skills and intuition to design that.
So if you do a significant IPR, let's say like from 6 to 6, and they tell you to do 0.5 millimeter, or okay, like
you gain 7 millimeter with that, yes.
You're doing that for every single tooth. You're doing 0.1 millimeter safety net, right?
Upon minor safety net, yes.
Is that gonna add up significantly?
It will add up.
Yeah.
But rarely you end up having that much of 0.5 on every contact.
Okay.
And the other thing that you can do that's actually a very brilliant question.
Yeah.
We do IPR 6 to 6, you're 0.1 short. So it's about 0.7 millimeter discrepancy right there. If that's the case, to us, like, as soon as you start seeing that IPR spaces are closing, you can check with your floss. If the contacts are too tight, and that's one of the things that you almost check every time patients come in. You check the contacts, because sometimes the contacts are too tight. That's why the teeth are not tracking.
Gotcha.
So if the tooth is not tracking, it's not always to blame the patient, because sometimes it's the way that we set up the teeth. So, and if you notice that, then you can run your IPR strip a couple of times, really gently, just loosen up that contact, and you'll be good to go.
Gotcha.
So you can always make up for that 0.1 if you experience a really tight contact here. But that was a very good question. And then, so you give them basically 13. Remember, we were like 7 days. And now at this appointment, I give them 13 to 28. I'll tell them now do 5 days and up. So here is a good important point to keep in mind. I had this Dr. Dissinger actually came from San Francisco, give us a lecture at the study club. He spoke for OMCO. And he said that my aligner patients, I tell them, you change your aligners 3 days and then 4 days, 3 days and then 4 days. So I dictate to them exactly when to change so they can know which day of the week. And that's like a big, big red flag to me because I never do that. Patients come in that say, every Friday night I change my aligner. And I look at them, a lot of time, those are the patients that the teeth, they're not tracking really well. because they're not in driver's seat. They're on autopilot. Change the aligner, it's Friday, change it, and all goes. But if you put the patient in the driver's seat and tell them, hey, it's 5 and up. These aligners are designed between 5 to 10 days, and every individual is different. And you talk to them about feeding well and feeling well. Feeding well is the aligner is tracking, the teeth and the aligner are fit. And feeling well, they go in and out easy. So when you put the patient in the driver's seat and you tell them every time at that 5-day point, if you're ready to move on, then check in the mirror. Check the feeding and feeling well, both of them together, and then move on. Since I started doing that, first, patients are having a better experience, and tracking has significantly been better than dictating. Even that's why I say 7 and up, and then I'll do 5 and up. And in the background, what am I communicating with the patients? They started with 10 days, and they did 7 days, and now they're 5 days, so they're going to do the math. Oh my God, that means I'm basically doubling up the speed of my treatment. So in their subconscious, they know they're making improvement. I even had a patient, I asked him, and he was like tracking really well. Say, how often do you change your aligners? And he was like, to be honest, I never look at it. I just, as soon as they feel good and they fit go, I change it. It can be 3 days, it can be 10 days, I don't know. I don't even look at the days anymore. And I loved it. I think I've done my job coaching him. Because he was in driver's seat, he was going fast. Some of his aligners, he would change even 3 days, but everything was tracking. So that was perfect. So I didn't have to dictate to them. Because adults are, and people are intelligent about their body. Sometimes we as doctors, we discount that. They are intelligent about what's happening to them. We have to rely and give them control. That's my personal philosophy. And then the other thing that's important that I've seen, a lot of colleagues don't do that. And few patients that are referred to me by my general dentist colleagues, like halfway, the case were not finished, and they say, hey, doctor, do you mind finishing up for me? Patient come in, and I go over the clean check with them. I show the patient, look at the lateral incisor movement. This is the molar, these are the limitations. I put them on the biggest screen, show them every teeth. And without exercise, person go, wow, I never been out, really? Or not? So that's great point. First of all, you bond and build relationship with your patient. Second, when you tell them about what's happening, they do much better job with the aligner. So almost every time they come in, look at the aligner, clean check with them, and tell the patient, okay, in this stage, keep an eye on your lateral incisors because they are moving a lot. In this stage, look at the lower canines. In this stage, this second molar is moving. Keep an eye on that molar. And then you get a much better outcome. So that's really important too. And this is like a great story of this patient. This is one of the patients that referred to me by a general dentist friend in Scottsdale. And he said this patient has been in aligner for 4 rounds of refinement. I think this is, I did the 13 revisions. I did her 4th round of refinement when she came in. And of course the molar is here. And patient had bad oral hygiene. She was a manager at Starbucks. Really nice lady, good looking, very classy, but very bad oral hygiene and poor compliance with the aligner. The first appointment she came in, so I'm not going to lose anything. If I fix that molar, perfect. If I don't, it's not going to happen. I told the patient, so these are what we're going to do. I educated her about this. Look at this attachment for the extrusion. I added attachment in here versus this one. And of course, she lightened up. And truth be told, in this one refinement, she finished the treatment. Her oral hygiene improved. Her treatment finished. The lateral central incisors were leveled. And she was in aligner treatment for 3.5 years. And she never had, and I know my friend, she's a great dentist. It's not that she neglected her, but she didn't know this little thing. Because she's an excellent dentist. She's very successful, multi-million-dollar practice in North Scottsdale. And she takes great care of patients. She has great hands, good knowledge, and everything. But she was neglecting that patient needs communication. They're going through this thing for about a year and a half. It's uncomfortable. They have to wear this piece of plastic. You gotta be on the team with them. Same thing that we discussed a couple of times. You gotta communicate, stay engaged in their life. So we are in this together, basically. And you can see here, see I put that attachment. This tooth was kind of flat, and there was a lot of movement. So I put that attachment there, and yes, luckily the tooth moved in place as we planned. The other thing is, in the progress report, it's good to, if you feel sometimes, take photo, panel. These are a judgment call. These are not this absolute thing. But it's a good idea. And the communication. And the other two terms that we have, it's mid-course correction and refinement in the progress thing. Mid-course correction is what we did today. This patient is coming. At the beginning, she was not compliant. So the central lateral incisor were not following. It's just like a 1.5, 2 millimeter gap. But this time she said, you could see that she's honest. She said, I'm doing it 24/7. I just take it that. And I felt we are falling off track here. So we didn't make patient uncomfortable. We said, okay, perfect. You're doing a great job. Keep it up. But now Michael and I are going to do a mid-course correction. So basically, pause, take a scan. And in any way of the treatment, unless there is a serious damage happening that we have to communicate with the patient, we have to tell them the file broken. You have to tell them. Or we missed the tooth, we pushed the root out of the bone. We have to communicate that with that patient. Whatever the cost is, we have to do that. But if there's no damage to this patient, like she's doing a great job, the aligner is not fitting, there was no point that I make her uncomfortable. I say, I'm doing a mid-course correction, oh my God, things are falling off. And it's impossible that you can educate patients on those details because they freak out. They mother bear for themselves, come out, and they feel you're doing something wrong, when in fact you're not. So don't make patient uncomfortable, take the scan, and just revise the treatment, like start fresh. You go from aligner 1 to 10, you see something is off, you didn't pay attention to something, patient didn't do right in following, just pause, take a new scan, don't make patient uncomfortable, and do a mid-course correction. Which most of the comprehensive cases, they come at no cost because you can get as many additional aligners as you want. And the other one is refinement. And sometimes about 50% of the patients get, as I said, refinement. In the hand of some orthodontists, they have their philosophy is, I do the initial round like quick, and then I'll definitely do 2-3 rounds of refinement at the end. But my personal philosophy is I spend a lot of time up front to hopefully either finish with the first round or one more refinement and then done. So I think I can recall in past 6 years, maybe I had 2 patients that they went to the 3rd round of refinement. The rest of them were done in the 2nd round at most. These are the 2 terms to keep in mind. Comfort visit, not that important. But the common concerns that patients have, it's usually the feeding problem. So it's a good idea. You can either do a Zoom visit with them and look at what's the feeding problem they have. Sometimes it's perfectly fine, just a little gap between lateral incisor or something. With patients like really sensitive about it, they make them uncomfortable. If something like that, of course we don't even have to see them in the office. You can do a Zoom visit and give them the comfort. Say that's good, just continue. We'll take care of that when you come in. But it's one of those second molar thing, then you have to see them in the office. And it's off of every individual patient. So you got to check the progress, check the clean check, and check the compliance to see very easy that the things are falling off track, why the aligner is not fitting. The other common concern aligner patients have is a lost or broken aligner. Most of the time, they lose maybe 2-3 aligners, but you don't give them the whole box. Or they break one aligner. Especially with reducing the velocity and increasing the number of aligners, you can always, even I've had patient, she lost like 4 aligners. I told them, take a Tylenol, put the 4th one in, and of course I check the clean check to make sure we can do that. Sometimes it's impossible. Certain movements happening in that part, then you have to order additional aligner. But to save time, and it doesn't matter to order another one, it just takes time. It takes about 2-3 weeks to order the new set of aligner. But if you make patient comfortable and tell them, hey, do you mind to have a bigger jump and bigger stretch so we don't waste time or we want to even save time? So you're not, first of all, you're not punishing them for losing. And at the same time, you're giving them like advantage. The only thing is they might have like a couple of days of hard time to fit that new aligner in. The experience that almost all the Smile Direct Club patient experience, tight and painful. So have them to order replacement or jump forward with the aligners, depending on, and that's also comes with your clinical judgment, how to troubleshoot that. Broken attachment and buttons, as I said, you tell them we don't rely on that, don't stress about it. When you see them, depends on the movement of the tooth and the anatomy and everything. Make the judgment call. Do you want to repair the attachments or do you want to let it be? And then sharp edges of the aligner, that's not very common, but I see every now and then happens. It's like a manufacturing defect or something. If they bring it to the office, you can polish it for them, or you can tell them, hey, don't be scared of, get a nail polish out and polish the sharp corners for yourself. And As long as you don't compromise the integrity of the appliance, it's okay, you can do that. And that gives patients a lot of comfort. Debonding and record. I go quickly over these and then we can talk about it for sure. It's not a certain order. I like to look at it from this order. First of all, the patient satisfaction. And I always give patient a mirror. I remember one of our teachers back in dental school said, never do that, because then nobody's going to look at you this close and make you uncomfortable. So encourage patient to stand back, look at mirror. But I personally don't like that. I give mirror to the patient. I say, look closely, because I know when she goes home, she's going to do this. So she better tell me right then instead of being home and being mad at me not seeing something. So I give them, say, look at it. What do you see? What are your concerns at this point? And there's another key. It's your general dentistry or orthodontics. Don't make people sensitive about things that they're not sensitive about. Midline, we know by literature, by science, by example, midline doesn't matter. Up to 4 millimeter upper midline even doesn't matter. Forget about upper lower midline discrepancy. And if you make the patient uncomfortable about their midline, then you're in trouble forever with that patient. Unless the patient says, this is my concern. Of course, then you do communicate, you get into it. Same thing with the final finishing. We give the mirror to the patient. You might see like few areas of improvement, but you don't talk about it. Let's see what patient's concerns. Give them a mirror and after. If the patient is satisfied, if they're not satisfied, of course, you decide about refinement or adjusting or all that. If it's not, then look at the smile aesthetic, smile arc, smile line, leveling, gum tissues, and all of that. If everything is to your satisfaction, then check the interproximal contacts. If the contacts are good, but a little loose, especially on lower arch, I'm not too concerned because I know the lower teeth are going to move forward and it's going to fix the problem. Or if the contacts are too tight, then I know I have to do IPR, I have to do refinement. And the upper molar contacts. And patient sensitivity in that world is a little different. Sometimes they have like loose contacts, they don't complain. Some people have like nice contacts, the food gets impacted a little bit, they are upset about it. So that's based on the individual. And then next we check the function, bite and phonetics. Phonetics, I've never had anybody complaining about, say I'm lisping because of position of my teeth, or I'm a singer and something is going to change. Usually the tongue adopts for it. So phonetic would end up being, I just put it in there for the comprehensiveness of this check. And then radiographic evaluation is just the root position would be important to see they're not, the tip of the roots are not kissing, or they're not too far off. That pushes the stability out. It's a good idea to, before making that final call, say this is the end, take a panel and look at it. And then removing attachments and buttons, just common sense, polish it off. It's a good idea to use like the black stone enamel polishing bar. Have you used them? Have you seen them? Those are really good. They usually break off and they're expensive, but that's okay. Especially if you have attachments on the front teeth or remove brackets on the front teeth, it's good to clean it up and then have a lot of water and then use that black stone. Even if they break, but they just do a good job keeping the enamel shining and fresh. That's a really nice way to finish the treatment. And then retainers you can make in, if they're like minor movements that are not done and everything else is perfect, it's minor rotation of the lower canine. I would say order the retainer off of the last aligner, because that retainer is going to over time fix that problem. But if you see the bite is better than you have on the setup, then don't order off of the last retainer. Take a new scan and order a new set of retainers, either from the lab or the same aligner company. So but that's important to do it. It's better to do it chair side. It just happened to me today, yesterday. My assistant said, hey doc, remember Amber? I don't see her on the schedule. We debonded, finished her aligner last week. Like, oh my God, I totally forgot to submit her retainer. So I just jumped in and submitted her. We did the scan, I forgot to do it. So it's good when a patient is sitting there, just do the scan, submit, and order the retainer right there. And if you're taking impression, make sure to take an impression right there, put it in the plastic, mark the lab while patient is in your chair, give it to your assistant or whoever to deliver it to the lab technician, and have the assistant to call the lab to come and pick it up. Because that also happens a lot. It happened to me before. I had like one impression sitting in the fridge for 2 weeks, and the assistant came, hey doc, by the way, we took impression of this patient 3 weeks ago. what did you want to do with that? I was like, oh my God. Call him back, we're going to take a new set of impression. So do it right chair side so you save those headaches. And then refer for dental and perio eval, which you're going to do that. Always after orthodontics is done, it's good to just have the patient to see a perio. Of course, we're going to be at the lines, we're not going to have any hygiene problems and things like that. But have the cosmetic from orthodontist perspective. I always have a general dentist, cosmetic dentist to look at it. And from your perspective, definitely keep an eye on those changes after they're done. And the brief summary is basically, what questions do you have? Oh, we did, sorry, I wanted to do it hour and a half, but went over. I mean, we'll be just hour and a half. Yeah, you started a little later, so.
We appreciate it.
My
Yeah,
pleasure,
This
thank
is
you.
really helpful.
Does that give you that 10,000 feet view that I intended?
Yeah.
Exactly that.
Give me some feedback. Give me some feedback.
No, I like it. I like that.
And
as
to
a
design that-
general overview to get your feet wet a little bit.
Okay.
Yeah,
Yes.
I like it.
Because that was important for me. I wanted you to see from the beginning to the end. Even when I go to a friend's house, I always, if it's not a rude thing to do, I try to walk around the house, go to the backyard, to get myself familiar with the environment, see what frames on the wall, where's the restroom, where's the bathroom, and all of that. So I do that, and then I feel comfortable, go sit in the living room and enjoy the party. I wanted to have that kind of view, so you know what are the treatment strategies, what are the diagnostics, what is it that an orthodontist years in practice sees when you look at a case. Now you see all of that. You might not know all the details, but you know the whole thing. There's nothing out of this. I might have missed a few. I think it's a big claim to say I didn't miss anything. But in the big picture, I think this is it. This is the boundaries of your aligner therapy. Okay.
A lot of good tips, practical tips too.
Practical tips. That was it.
That was totally helpful. Yeah. A lot of times you learn in the theory, but then we get on the computer, and it's like to make that gap. We don't have the kind of experience to make that jump, so that's helpful. To kind of
Lovely.
real
lovely.
solid, concrete tips and ways to overcome.
Perfect.
That was helpful.
Perfect. I'm glad to hear it. And well, I would love to do, let's see if we can, just sit an hour, review 5-6 cases on Invisalign platform, on 3M platform, on the Spark platform. You already experienced a little bit of Suresmile. So in case you walk in an office and they say, okay, this is a clear, correct office, then you say, hey, I'm familiar, I've done it, I've seen it. And that's going to be good. So we can review maybe 2 cases on Invisalign, 2 cases on 3M, 2 cases on the Spark. These are the premium ones.